So it's my pleasure to introduce our next speaker, Mark Okusa, who's professor and division chief for nephrology at the University of Virginia. He's going to speak to us about neural control of multi-organ dysfunction in AKI. Welcome.
Thank you, Kathleen, and thank you, Dr. Mehta. It's really been a privilege to be here over the years. This has been a wonderful meeting. So what I'm going to talk to you about over the next 15 minutes is how the brain can be very important in controlling inflammation. And I spoke a little bit about that yesterday, and I'll continue with some other organs that might be important. So these are my disclosures. So all of you are familiar with this scene. There's patients that have, and back in 2020 when COVID came out, multi-organ dysfunction, and every day we see patients with sepsis now with multi-organ dysfunction. And so this is a slide which illustrates the different organs that can be involved, from the lung, liver, kidneys, the nervous system, heart. All these systems can be involved, and the vagus seems to have an advantage in terms of its distribution and innervation, and the potential exists that we can take advantage of this unique anatomy. And so today what I'm going to talk to you about is three areas: the lungs, the kidneys, and the GI system. So the vagus nerve, also called the wandering nerve, this is the longest nerve in humans, and it was described many years. Otto Lowy isolated the first known neurotransmitter when he found that the substance was released from the vagus nerve, which we now know as acetylcholine, and it calms the nervous system and counters the fight or flight. This neurotransmitter was originally called Vagostoff, German for vagus substance. So the hypothesis is that the vagus nerve can provide a calming effect in the face of a cytokine storm. So to put this into perspective, I want to present a case, and this case is very similar to one Stuart Goldstein presented yesterday. So if you were there for that case, this is very similar. This is a 54-year-old male with X-linked chronic granulomatous disease, CYBB mutation, which is a mutation in the FOX21 subunit of NADPH oxidase in neutrophils, which makes reactive oxygen species. So these patients can't make ROS from neutrophils. He had gene editing done and hematopoietic stem cell transplantation. But this didn't really work because all the neutrophils that were corrected in terms of making the ROS kept getting destroyed in the periphery, despite the fact that he was on sirolimus. He's maintained on prophylactic medications. He had presented with lethargy and appetite loss for 2 days, became altered overnight, short of breath, diarrhea, presented to the emergency room with increasing confusion. This occurred so rapidly. I've never seen a case that where a person reached his demise so early. In the emergency room, he was disoriented to place, time, and situation. Vital signs were stable. He was initially given antibiotics in the emergency room. In the MICU, he was evaluated. He was tachypneic, intubated, and he was managed further there. So on examination, he was lethargic. He was in respiratory distress. Otherwise, really, it's the neurological symptoms that seem to predominate. His laboratory exams, his platelet count was 85,000, lymphocyte count was low. He had acute renal failure on top of chronic kidney disease. He had an anion gap of 14. Liver enzymes were slightly elevated. He had a mixed acid-base disorder. His ferritin level was 2,299. His SUD rate was 125. His CRP was 20.3. His chest X-ray is shown. So he was continued on broad-spectrum antibiotics. There was concern for this entity called hemophagocytic lymphohistiocytosis, or HLH. And for that reason, soluble CD25 receptor and IL-2 receptor were sent to the Mayo Clinic. And in retrospect, after a week or so, the labs came back and his soluble IL-2 receptor level was 8,849, which is tenfold higher than the normal range. He had refractory shock, and he was on 3 vasopressors, had lactic acidosis, and uric acute kidney injury. Because of the presumed HLH, he was started on Decadron and IL-6 to combat the cytokine storm. His blood cultures grew of 2 gram-negative rods in the beginning, and later identified as Burkholderia gladioli. This is a very unusual organism, occurs in immunosuppressed patients. He was on 4 vasopressors, including angiotensin II. He continued to do poorly, and CRT was started, and the following morning his family requested comfort care. So this was really a dramatic case of someone who had a massive cytokine storm. And so the problem with this person was that he had a defect in the production of reactive oxygen species. He has a mutation in the GP91 FOX, which is one of the subunits of NADPH oxidase, which is important in transferring electrons to molecular oxygen. And then this it undergoes conversion to hydrogen peroxide, hydroxyl radicals, and hypochloric acid. And so this defect then prevents them from making these ROS products. So hemophagocytic lymphohistiocytosis, it's a pro-inflammatory, it's a disorder in which there's a pro-inflammatory response because they can't make NADPH oxidase. The innate system is impaired. There's activation of the adaptive immune response, such as activation of CD8 T cells. There's overactivation, proliferation of macrophage, and he has a hypersecretion of several cytokines, basically cytokine storm. There's a phagocytosis of bone marrow cells and reticular endothelial cells of other organs. So this is nicely fits into the concept that Hotchkiss presented back in 2013 in Nature Reviews Immunology, in which there's a hyperinflammatory response. And there's also an adaptive response to counteract that. But if you don't have a strong enough adaptive response, there's an overwhelming hyperinflammatory response, which then leads to early death. And what I believe is prominent in this is that neural mechanisms can, in part, control this. This is an area that we've been investigating over the last decade, in which we took advantage of the knowledge that Kevin Tracy has provided, in which he described the anti-inflammatory or the inflammatory reflex pathway. And what this is that in the peripheral organs, there's sensory neurons that respond to toll-like receptor agonists, PAMPs and DAMPs, which leads to afferent signaling to the nucleus tractus solitarius. Then there's an efferent pathway that leads to the celiac ganglion. The adrenergic nerve then enters into the spleen, releases norepinephrine, binds to the beta-2 receptors on T cells, and these are CHAT-positive T cells. That is, they make acetylcholine. So unusual in that immune cells are producing a neurotransmitter, which binds to the alpha-7 receptor, leading to this anti-inflammatory effect. Over the years, we've investigated the neural circuitry of this pathway using various techniques, such as electrical vagus nerve stimulation, or optogenetics, where we would introduce light-sensitive proteins into a pathway. And because the vagus nerve is heterogeneous, this allows us to interrogate individual pathways selectively. And then by serendipity, we found that this whole system can be activated with pulsed ultrasound. This is using a clinical ultrasound machine that is used within the guidelines approved by the FDA. And so whether it's electrical, optogenetics, or pulsed ultrasound, if you don't have a spleen, there's no protective effect and no anti-inflammatory effect. If you take out the beta-2 receptors, denervate, or if you take out the alpha-7 receptor or do a splenectomy, the effects of pulsed ultrasound, electrical vagus nerve stimulation, or optogenetics becomes ineffective. This is an early example of how ultrasound can be very effective, and that if you administer ultrasound 24 hours before ischemia reperfusion, you can see there's a marked protective effect as opposed to animals that did not receive pulsed ultrasound. And if you look at the plasma cytokine levels in response to ultrasound, you can see there's a marked reduction across the board in terms of all these cytokines, pro-inflammatory cytokines. If you look at a LPS model of acute kidney injury, we were able to show that pulsed ultrasound attenuates the LPS-induced increase in plasma creatinine, various cytokines, including IL-6, interferon gamma, and a whole host of other cytokines. KIM1 expression in the kidney. And shown to the right is a KIM1 expression. And you can see that ordinarily when you have saline infusion, you can see the proximal tubules outlined by CD13, which labels the brush border membrane of proximal tubules. If you administer LPS, you can see that this red color then becomes very prominent in the proximal tubules, and this is KIM1 expression. So there's this injury molecule that's being expressed, and you can see this co-localization in the brush border membrane. But if you perform pulsed ultrasound treatment, you can see that this red color is, and KIM1 expression is markedly diminished, indicating the protective effect of pulsed ultrasound. If you do some other assays, if you look at the kidney ATP level, there's LPS induces a marked decrease in kidney ATP within 40 minutes, and this is partly reversed by pulsed ultrasound. And if you look at NRF2 levels are maintained for the first 12 to 24 hours, but then it rapidly drops off, and this rapid drop-off is prevented by pulsed ultrasound. So there's a number of protective effects of pulsed ultrasound in animals subjected to LPS-induced sepsis. Now, the microcirculation is very important, and in this illustration here is provided by Bruce Altoris, in which he looks at the paratubular capillary, and these are all leukocytes that are in the paratubular capillaries. When you have sepsis, there's adhesion molecule expression. These neutrophils and immune cells adhere to the endothelium, leading to a decrease in flow, sometimes a reversal of flow. This leads to a diffusion-limited region of hypoxia. And so normally oxygen diffuses to these regions, but when you have lack of flow to these vessels, you have areas of hypoxia. And we used a method that is called photoacoustic microscopy. And Song Hu was a biomedical engineer in our institution who helped with these studies. And essentially what he showed was that if you used laser and excite the kidney, this then leads to optical absorption, and it transmits heating, and it then leads to thermal expansion, which is then detected by an ultrasound device. And some of the images you can get are shown here. This is the retina, and the lung is shown on the other side. And so these are impressive photoacoustic images. But you can also measure hemoglobin saturation, you can measure oxygen extraction, you can measure red cell flow. And so we perform those after LPS injection. And just to show you one example, this is a metabolic rate of oxygen. And this is essentially oxygen extraction. And when you administer saline, you can see that there are some red areas in which there's a significant amount of oxygen extraction that occurs. And this occurs in areas where there's a lack of flow or decreased flow. If you administer LPS, you can see this marked increase in oxygen extraction or metabolic rate of oxygen. And this is prevented by LPS and ultrasound treatment. So again, the microvascular circulation is improved in the presence of ultrasound. Now, turning to the lung, we all encounter this in the intensive care patients that are septic and have multi-organ failure. We performed additional studies in which we looked at not ultrasound, but vagus nerve stimulation to look at the effects on immune cell accumulation in the lung and also tissue histology. And for this model, we used an intratracheal injection of LPS. And what you can see is that prior vagus nerve stimulation led to a marked decrease in total CD45, which are immune cells, neutrophils, alveolar macrophages, interstitial macrophages. And if you look at the histology, these nice lacy-looking appearance is the alveolar walls are thickened in the LPS and then again attenuated with vagus nerve stimulation. So the vagus nerve can have a protective effect in the lung as well. And we know the GI tract is innervated by the vagus nerve, and this is Steve Lieberle's, which demonstrates the innervation to the stomach and intestines. And there are a number of different studies which show that if you have different models of trauma, whether it's traumatic brain injury or whether it's a hemorrhagic shock, what happens is the gut epithelium becomes different. There is increase in permeability. There is intestinal permeability, which is increased, and then this is improved with vagal nerve stimulation, and you can see the histology is improved as well. So with abnormal permeability, with the loss of tight junctions, there's bacterial translocation which can occur, and this can lead to worsening of sepsis. So what I tried to show you is that there's opportunities in which we can protect organs, multiple organs, whether it's lung, kidney, or the GI system. Other organs can be protected as well, including the brain. And so the vagus nerve is situated in a place where it might provide this protective effects to calm the immune system and perhaps attenuate some of the cytokine storm that exists during early sepsis or COVID-19 infection. So I'll stop there, and I want to thank again Dr. Mehta for this kind invitation.